So without further, I'd like to introduce Dr. Lenny Sender. He is the Director of Clinical Oncology Services at UC Irvine. Dr. Sender wears many hats. He's also the Director of the Cancer Institute at the Children's Hospital in Orange County and the Division Chief in the Department of Oncology at the Children's Hospital. Dr. Sender.
Dean Bailey, Dr. Rosen, Dr. Gupta, Dr. Ang, and ladies and gentlemen. My talk's going to be a little different to what you've just heard. I really want to introduce you to the topic of what is called an adolescent young adult oncologist and what are some of the issues that we are dealing with and the ethical challenges that we have in taking care of our patients. And to do that, I want to give you a definition of what an adolescent young adult patient is, and this is the symbol from the London Underground, where the movement called teenage young adults was born many years ago to deal with this population. Under the age of 40, there are 70,000 patients who are adolescent and young adults. And the definition is 15 to 39. So there are 1.4 million Americans who will be diagnosed with cancer in 2008. In the traditional methodology, we broke it into two types of cancer patients, the pediatric cancer patients and the adult cancer patients. We now think of four different groups. We think of pediatrics, which is up to age 15 to 39 being your adolescent young adult, then adult cancer patients, and then geriatric cancer patients. And we've gone from lumpers to splitters, and we may split more. They have many different cancers, but more intriguing is the differences in the types of cancer that they have. So what makes this a unique group to take care of is the fact that most little kids have embryological types of cancers, neuroblastoma, retinoblastoma. And as you get into the more pediatric age, you start seeing the medulloblastomas, not the standard gliomas. You start seeing acute lymphoblastic leukemia, non-Hodgkin's lymphoma starts coming up. And then you hit the group that I call the AYA group, the group that has thyroid cancer, melanoma, connective tissue diseases, and we're going to talk about osteogenic sarcomas, Hodgkin's, and germ cell. And then you get into the adult cancers, which is the carcinomas. So 75% of all the cancers that exist in this country are lung, breast, colorectal, and prostate cancers. And only a very small percentage are the group that I take care of in this adolescent young adult space. This is just to show you, if we break it up by age groups, and this is work done from the Department of Epidemiology here at the university, where we looked at all the cancer patients in the state of California, and you can see males versus females in the 15 to 19 age group. You can see something that's very interesting that probably most people didn't know, that melanoma was about 11% of the girls in that age group, and in males it is about 7%. But then, as you get to 20 to 29, you start seeing that you're getting cancers. Here, 15% of the females have got melanoma, and 19% of the boys have melanoma. You don't see prostate cancer. You're not seeing lung cancer. And then when you get to 30 to 39, you can see, unfortunately, 28% of all cancers are melanoma. And in the females, breast starts occurring, and in this group, it's 11% of melanoma. So there are different types of diseases. We're going to talk about sarcoma. It's an orthopedic meeting. But I wanted to introduce you to the concept that we talk about different types of cancer patients. So why should we even talk about this? Why should we even decide to even debate whether there should be differences in patients in this age group? And it's because of the outcome gap that's been developed. And this is what's happened to us over the years in how we've done with our patients. We've done extremely well. We've gone from low survival rates into some of our acute leukemia patients I take care of in the pediatric range, 90% cure rate for a child diagnosed with acute leukemia under the age of 10. However, we have not seen any improvement in the group between 15 and 29 and 15 to 39. And in fact, I will show you that they've got worse. And the question is why. So in England, because of Mind the Gap, if you've ever been there, it's underground, so you don't fall through the cracks, and we believe that this age population falls through the cracks. So let's look at the clinical trials gap, and let's see what actually we understand. So here, that's very interesting data. There are only 12,000 children under the age of 15 who are diagnosed with cancer, but 5,000, you can see the numbers, 5,370 boys were put on clinical trials, 4,537 girls. Now look on the other side, over here, this is females, 30 to 39, and you've got 4,900. There are more than 3 times the number of cases in the age between 15 and 39 that are between 0 and 14. Pediatrics has been very successful in creating an academic environment in all pediatric oncologists to put patients on clinical trials. It is absolutely accepted norm. Now, something interesting, some of you may notice the slightly cute colors that we chose, were that their parents will more likely put a boy on a clinical trial as under the age of 15 than a girl. And you can see that women are smarter than men because when they're older, more women went on clinical trials than men. Now, this, just to show a quick snapshot, this occurred across every ethnic background and every demographic we looked at. So it doesn't make a difference. But something that's very interesting is, hope when I'm seeing the V, if you look down, clinical trials drop down dramatically in the 15 to 29 and start coming up in the 30 to 39 age group. But 15 to 29, a tremendous paucity of patients going on to clinical trials. So, big deal. So they didn't go on clinical trials. Did this mean anything? Well, here's the accrual, and we superimpose the cancer mortality and reduction. And for the statisticians in the audience, this was statistically relevant. So there was a correlation between going on a clinical trial and improvements in outcomes. And when we looked at another factor which was the change or the percentage change of improvement, you can see pediatrics did pretty well under the age of 15. But when you start seeing the adolescent young adult, we start seeing dips. We actually were doing worse than we had done previously. And again, when you correlate patients going on clinical trials, you can find that again to be statistically significant. So I just want to highlight 2 cases for you quickly to give you a flavor of what we're dealing with and the ethical challenges we deal with. So first is a young boy with melanoma that I'm treating right now. He's 17 years of age. He has stage 4 disease with liver metastases. He's not eligible for any clinical trials because there are no clinical trials open to anyone under the age of 18 in this country. I want to state that again. There are no clinical trials, but I told you that 11% of patients who are diagnosed between 15 and 21 have melanoma. Then we asked for compassionate approval. There were some interesting trials. We tried to get FDA approval. We tried to get the NCI to approve it. We're still waiting. He waits, the tumor grows. The median survival metastatic disease is 8 months. So I asked, what are the ethics of not having studies for patients less than 18? We need the FDA, we need the academic community to demand that young melanoma patients or young adults with cancer have access to care. Remembering 10% approximately have these melanomas. Now, let me move on. I'm an orthopedic comedian. I'm sorry I don't put in devices. But let me tell you what we know about osteosarcoma. So osteosarcoma is the third most common cancer in adolescents, occurring less frequently than lymphoma and brain tumors. About 60% of malignant bone tumors occur during the first 2 decades of life. There are about 550 cases under the age of 20, 150 cases under the age of 15. So it's not a very common cancer. It meets Dr. Rosen's definition, Dr. Sturt's definition of an orphan disease. In fact, the whole field of pediatric cancer is an orphan disease. This is what it looks like, as you probably know. This is what it looks like grossly, and this is what it looks like, just to make Dr. Bailey remember he's a pathologist, this is what it looks like as a pathologist. But in the 1980s, there was a controversy. At that time, people weren't accepting that maybe adjuvant chemotherapy actually was beneficial. So there was a breakthrough study that was published in the New England Journal of Medicine. Things were a little easier back then. I'll show you why. And this was a breakthrough because they did 36 patients. And that study, 36 patients, and they showed that the 2-year survival had improved from 17% in the control group, which was similar to data that had been published in the 70s, to up to 66%, and they were statistically significant. Now we're facing a new controversy. So we've gone on since 1986, it's now 2008, and now we have a new controversy. Do we add a new drug, or is a new drug that's just been published a drug that we should be adding to the armamentarium? So there were 2 papers published by Dr. Myers. Paul Myers is actually, I think, Dr. Ong's one of his mentors from Memorial, in full disclosure. And they published a paper which showed that the addition of a drug called MTP in a randomized fashion improved outcome. And they also showed that there was a relationship with ifosfamide, a drug. So the first thing they showed was a significant interaction with ifosfamide, but this had no significant impact on event-free survival. Then in 2008, they gave the follow-up, and this is now the largest study ever done in the world on osteogenic sarcoma. And the data showed that in this time now, all those years later, we actually have a trial of 662 patients. And in this one, they randomized patients to receive this new drug called MTP, which is an immune modulator, which had been shown to potentially improve survival in the 2005 paper. But what they did is they changed the chemotherapy, so you weren't measuring an apple and an apple. You're measuring apple and an orange. And if you take it that this is the largest trial and took for so many years, someone should have thought about why you're making that difference so that you can't compare. So what gets complicated? The one trial had cisplatin, the second trial didn't have cisplatin. Was an interaction between cisplatin and ifosfamide. So how do you actually compare those trials? And then there was, in the 2008 paper, there was this trend for better event-free survival and improved survival. Again, was this relevant? Well, why is this relevant? Why am I bringing this up? I'm bringing it up because this drug may be approved by the FDA. There's a trial that says it had an improvement, but if you really look at it, the trial maybe didn't have a real improvement. And this is going to be an expensive drug. It'll cost about $60,000 per patient. There are 550 patients. It may seem a tiny part of the United States healthcare budget, but it does bring up a point of how do we actually go about making those decisions. So I've developed a term, which I probably stole from someone, but I use this term called academic detailing. So the pharmaceutical industry would love this drug, the FDA to approve this drug, and there's a lot of pressure to improve it because in 10 years there's only been one new drug for osteogenic sarcoma. So academic detail is trying to understand what's the ethical duty to our patient, and as Dr. Rosen has said, what do we know about the authors? Do they have a stake in the company? Do they speak for the company? Do the institutions benefit from the study and having the drug approved? And the answer is we don't really know. Yes, there's those disclosures in the journals, but they're not detailed enough to give us the type of information that we can make an informed decision. So I believe that we should develop academic detailing, which would counter what the industry does, which is called medical detailing, which is when they train their pharmaceutical reps on how to get across to us why they think that is a better drug or device. So let me talk about quickly the research ethics involved and the complications of taking care of patients in this age group. Approximately 60% of all pediatric cancer patients are enrolled in clinical trials. However, if there's an open clinical trial, about 80% will be offered the trial. But nearly all patients give consents, but can we really say this is a true consent? And I've listed some of the factors that influence the informed consent process, the capacity to understand. Here in Orange County, 60% of our patients are Hispanic, and when we do detailed analysis, we find that most of their parents only have 4th grade education level. Our consent form for the latest osteogenic sarcoma study is 27 pages long, and I would challenge anyone in this audience to really feel that they're understanding that complex informed consent. There's complex language, limb salvage, randomization, necrosis factors, chemotherapy responsiveness, obtaining assent distinguishing between the treatment and the doctor and the research investigator and the voluntariness of doing it. This just shows what the schema looked like. You can see it's complicated. You have to explain all of those arms of randomization to the patient, and most of these are between 10 and 20 years of age. So there's a principle of distributive justice, which means neither an unfair burden nor unfair exclusion from the potential benefits of research. Those not competent to consent shall not automatically be excluded from research that is potentially beneficial to themselves as individuals or the group they represent. So the question is, what do we know about our AYA population? Well, let me give you some facts. The type of protocols. We know that in acute leukemia, if we treat a patient according to an adult-like treatment plan, because they're between age 15 and 21 or 15 and 29, their outcome was 38%. And if you treat them according to a pediatric treatment plan in that age group, it's 70%. And I can tell you every single day I get called about someone in this county, in the state, in the country who's been treated according to an adult procedure because we haven't got it there. Then we don't have an open trial. The sad fact, and the dirty secret, is that there were no patients treated at UC hospitals in the last 10 years on protocol for acute lymphoblastic leukemia. And in the open trial, there were only 8 pediatric patients or patients under the age of 30 who were treated the last 5 years with malignant melanoma. So why is there discrepancy? I call it the ethical lapse of the academic community. The excuses that I've heard both from our local institutions and from others, the disease or condition is too rare, it's too expensive to keep low accruing protocols open. There are bigger fish to fry, old men with prostates and Congress, not an academic mission of the institution. So let me just recall what the mission of the university is. We should be doing clinical care, education, and research. So my challenge, and I agree with Dr. Rose, let's do the ethical thing. Let's start changing how we interact with the pharmaceutical companies. Let's start doing academic detail and put our money where our mouth is and do the right thing. Here at UCI, I'm proud to say that we are one of the few institutions that are doing the right thing. We have developed a young adult cancer program that is improving access to healthcare and increasing, that will lead to increased cure and meaningful survivorship. But this does take some money and commitment, and this is for Dr. Bailey. When I come to him asking for 3 ships, hopefully he won't tell me I only need 1. Thank you very much.